Hello and welcome to a new session. Today we are going to be talking about information architectures of the population health systems, of the population health information systems. Then the learning objectives for today are going to be to describe the basic functions and standards that we have in population health information systems. Even though we are going to have a specific session in standards, we are going to start approaching them. Identify the key features and type of population health information systems, and we want to distinguish between information systems at the health system level and the population level. Then with that in mind, let's start with a brief introduction. And basically the big difference between a health information system and a population health information system is that the health information system of the HIS, they are organized efforts to collect, maintain, and disseminate data in the performance of a health system. It could be any of these components or parts, or it could be the system in general. Then it's the performance of a hospital, the performance of an insurance company, the performance of a opportunity of care, or even the outcomes of the service, the satisfaction of the clients. But when we are looking at in population health information systems, we are focused on information that is aggregated, and it aggregates populations. The subject analysis is not the organization or the product of organization. The subject analysis is the aggregated data that we have surrounding populations. Then, for example, when we talk about population health information systems, we can have the time trend of obese people for the population that a clinic serves, or the trend of the population that the clinic actually covers. That's the population information that we are focused on. Is the outcomes, the evolution, and the unit analysis is the aggregated data about the individuals. While the medical or the health information systems is to find X individual that is particularly obese, or we filter with for some reason. Then, or what is the cause of depression of for a particular individual, or what is the cause of operation for the health system. Then, when we look into the key features that we see in population health information systems, we see that they are optimized for retrieval of large records databases. They are able to cross-tabulate the study trends, and we can look into patterns. We can use for personal, we can use the personal identifiers, but usually is very limited. We can have linked data, but we are not going to be able to re-identify individuals. And that linked data, the key maybe is not going to be available for us, but it's going to be available for the integrators of the data. Then the basic use of population health information systems basically is to expand or increase the access to information technology and integrated data, and is to promote the health exchange. Okay, and basically what we want from population health information systems is to have timely, reliable, and coordinated data, information and communication to increase the capacity to plan and implement prevention strategies. We want to detect and respond to threats to the public health, like when we have pandemics or outbreaks, and to facilitate access to health and social services. Basically, to how to allocate services. And when we think about the factors that are going to influence the use of those population health information systems, we are going to see that one of the biggest challenges, and as I mentioned, we are going to dedicate a whole session, is the interoperability, or the capability to bring different systems together. Also, the mechanisms of data sharding are the ones that are going to facilitate or make more difficult to access the actual data. The standards for data collection. If we don't collect the data in the same way, then we need to have ways of making them equivalent. And we also have concerns or uh, problems about privacy protection. Then, because if you want to collect data, and there are studies out there that we can re-identify individuals given enough data points or enough descriptors, then there is concern there when you even are trying to aggregate data, but when you have access to the database in the individual level, it could be problematic. And of course, how to analyze and be able to use that data to be interpretable. Then in that domain, or in that regards, there are different approaches in the ways that health information and population health information systems are developed. In the United States, we have this bottom-up approach, but basically there is a national health information architecture, and then we just follow that recommendations. There are top-down approaches, like in United Kingdom, where they have the National Health Services, but they start from enabling the clinics and helping them to build their data collection tools. Then at the end, you integrate that. And then it middle out approaches like Australia and Canada, where they build basically the highway of communication, and they say, okay, everybody's going to be connected here, and that's what has been established. Then now the population is derived product by the entry points that are the clinical devices are free also, but free to be designed in any way, and then the only thing that is standard is the highway. Then there are some advantages and disadvantages, but the thing is we can have flexibility in some standards. We can support evolution and innovation depending of the practitioners, and also there are different health information systems. And then when we have this bottom-up approach, that is the one in United States, it's kind of having a guideline that we are just jumping. And then in the US case, that is that bottom up, I'm going to go a little bit through the history. Then one of the first attempts that we had was the Regional Health Information Organization, or the RIOs, that were typically not-for-profit or neutral organizations. They provided open access to different participants in the region, and basically they bring together healthcare stakeholders in geographic area and governs the health information exchange. Basically, the goal was to improve healthcare and the care in that community in some national recognized standards. And the goals for those RIOs were to provide support for network connectivity, create virtual private network capabilities, provide the data exchange, the use of agreement for clinical data, create regional security services, optimize utilization of the existing resources in place, and preserving resilience through local variation and autonomy. Then we didn't really to adopt different languages or different interpretation of things, and we can be local. These were foundation in the health information efforts in the beginnings between 2005 2008, but they have some problems about funding and sustainability. And at the end, HITECH Act, that was one of the health information technology and health exchange regulations, didn't provide direct funding for the RIOs. Then they were having really big challenges to be sustainable. But in that domain, there were like different programs like the Beacon Communities, that they were able to extend these ideas not only in organization but to communities. And that HITECH Act that I mentioned, that was in the it was created in 2009 under the American Recovery and Reinvestment Act, and basically was promoting the adoption of electronic health record. And that adoption of electronic health record has to have a meaningful use. in order to incentivize the adoption of electronic health record, they expected to have some outcomes at the end. When we look into the history and the critical, the people were saying, hey, meaningful for who? No, because it was not really meaningful for patients or providers. Was more meaningful for the public health. And the meaningful use at that time was to improve the care coordination, reduce healthcare disparities, engage patients and their families, improve population and public health, and ensure adequate privacy and security. Those goals were not really attained, and it was criticized a lot because they didn't facilitate the work in the daily base to the providers, and that was one of those challenges, that the meaningful use and the adoption was not really there of the electronic health record. That program of the Beacon Community Cooperative Agreement, it was run between the 2010 2013, and basically they wanted to use the electronic health record data as a source for performance measurements, and they wanted to engage non-traditional care delivery partners, that means out of the clinic and then community health workers, midwifery, PTs, and they wanted to test new models for community-wide health information exchange capability, inspiring those RIOs, and they wanted to expand the reach of functionality of those exchange capabilities, and they wanted to develop and test different technologies, different care models. That was a really interesting idea. There were 17 communities that were involved, but as I mentioned before, this was one of those times where really were not they were funded just for the project, but there were not sustainability plans for the efforts. Then after the meaningful use, they brought a new name and a modification on the regulations, and then they called this the promoting interoperability, what was called before the meaningful use, and then looked that they have this switch in response to the critics. Then they wanted to emphasize patient access to the data. Then now we have the patient portals, we have the open notes concepts. Then the health information exchange is the new evolution of the RIOs. We also have the e-prescribing, and nowadays we see this like in a standard. No, you go to the doctor and then you can just show up to the pharmacy and pick up your medication. That was enacted from these regulations. And then the promoting interoperability for clinicians, they also have a quality payment program where basically they were looking for some performance indicators in order to compensate them, and this became kind of a backfire, because then now the people were more concerned in actually how to document and what to document in order to get paid more, than actually providing the care or doing this. And that was one of those adverse events that happened there. The Medicaid promoting interoperability for hospitals and health enterprises, it continues until it continues, but the Medicaid promoting interoperability, that was ended in December 2021. But let's talk a little bit about those health information exchange, because they still exist, and they were kind of the evolution of the RIOs. And what they were doing was electronic transfer or clinical and administrative information across diverse healthcare settings. And sometimes they could be competing, no? But these are neutral organizations that basically are bringing that data together. And when we talk about that health information exchange, is how we move the data or the information between different stakeholders in the healthcare sectors. And also we refer as the health information exchange to the organizations that is a legal corporation that facilitate that exchange. Okay, it could be within a network of facilities, it could be a community, it could be a state or a region. We have different levels of health information exchanges. But basically, it's to leverage integral information systems, and they want to exchange that data and information so that data is available when and where needed by patients, provider, and population health analysts. And actually, they can charge for the data. And that's one of the ways that they have been sustainable. And there are different health information exchange, and you can have states that have multiple and regions that they have multiple, and it depends to whom you subscribe is where the data is going. And it has some challenges sometimes, because you may be seeing two providers that they are connected to different health information exchange, then your data is not going to be linked. But there are different types of these health information exchange structures. Commonly, we have the private ones that basically is a health system that interconnects their affiliates, and maybe and then the exchange is only within the membership group. And examples are the VA, or that if you're not part of the VA, you can look to the data when you are outside of the system. There are also state and public entities. There are some state governments and other private organizations, but state funded, that facilitate that health information exchange. And that's within the state boundaries. And those are the ones that I already mentioned, that sometimes there are states that have multiple serving different regions, but they not necessarily cover everybody, and they may be competing for the data of the providers. Those activities are driven by public and policy priorities, and they typically operate in a technical level that is like a network of networks. Basically, data is pushed from provider A to provider B, and there is a single point of time. That information that is pushed is not stored in a central repository or retained in that state. And basically, this is in the model of referral and counter referral to mobilize that data. And it allows each state to have multiple, and where I was explaining, initiatives that they operate independently. Some of those organizations have created a data agreements to actually that data that is being transferred be collected and have secondary use. And this is even outside HIPAA, no? Because HIPAA is just in the transactionality of healthcare delivery, but the health information exchange is a completely different framework. We also have community-based health information exchange, and they basically involves exchanging that data or information in providers and healthcare organizations that may be in the same marketplace. They are not affiliated, and they don't have financial relationship with each other. Then organizations have recognized that are better served through a health information exchange, because this is the way that even though you have competitors, you may have access to your data, no? When you visit them. But also, if you don't share that information efficiently, then the problem is that you can have repeated tests, procedures, and there is waste in the system. And then when people don't exchange data, these type of things start to happen. They are vendor enabled. Then there are some electronic health record vendors or health information technology vendors that create these layers for health information exchange in top of the infrastructure that I already have. Then it enables the consumers to send or receive information with other vendors of the same electronic health record systems. I don't know if you have an affiliation with any organization that use Epic, and you may have access to MyChart. But if you go to different providers, you are going to have a MyChart for every single provider. It's not really an integrated exchange, but the data is there, but it's not really that fluid. If you enable some of the transfer of the data, that is going to happen, but that does not happen. It doesn't happen automatically, okay? And the vendor doesn't facilitate that exchange, but they retain the data, okay? And this is the pathway for the health information exchange. Then when we think about key components of health information exchange, then we need to think about the interoperability and standards, and those are prerequisites, because if we don't talk the same languages, then we are not going to have fluid. That's the reason why we are going to have a session using standards for health exchange in the future. Then we require that both social, political, and technical conditions be met, because if not, the data is not the data exchange is not going to happen. And usually the barrier is not in the technical condition, the barrier is in the socio-political condition. Then we need to create that trust, and that's one of the most important elements. And here is where we introduce these three concepts of privacy, confidentiality, and security. And actually, when we look into the regulation and the standards for health information exchange, they talk about this. And when we talk about privacy, is basically you have the freedom to choose which information is shared or not shared with other parties. The privacy is an individual's right. Is that right not to disclose information about themselves to others? When confidentiality is the counterpart, that is an obligation, is a duty to keep secret information that you have been entrusted with. Okay, then these obligations are imposed under the Health Insurance Portability and Accountability Act, that, as you may know, is called HIPAA. Look at that name, Health Insurance Portability and Accountability. In reality, when HIPAA was created to facilitate the health information exchange between payers and providers, but to restrict the use of data against the patients, because you may have information about the patient that then you are going to be denying services. That was the spirit of the act. Now we have used liberal ways HIPAA, but in reality, there are only some protected or covered entities that are obligated to follow this. HIPAA has really good principles about recognizing what is protected health information, but basically, what people say we are HIPAA compliant, is that you are aware of those health information pieces, and you have the security layers under and the different means to avoid an accidental disclosure. Then when we talk about security, is this the combination of administrative, technical, and physical safeguards to ensure those two things that we wanted: confidentiality and to promote the privacy. Then security is that prevention of inappropriate use and disclosure of information. Then strong passwords, encryption, physical door locks, and those are the different elements that that they are required or recommended in the different levels, because HIPAA not only covers electronic data but also covers physical data, and that's why having lock cabinets and safe rooms, things like that, are really important. There have been really big challenges to the interoperability and health information exchange related with cost, resources, privacy, interoperability, competition. The good news is we are moving forward into adopting national interoperability standards, and we were in the framework of the Cures Act. That evolution of these different resolutions that has been updated by both for the Office of National Coordinator and the Center for Medicare Services. And then the Cures Act, in the final rule, now we have a standardized APIs or programmatic access to health exchange, and the standard factor is FHIR. FHIR is a flavor of HL7, and we are going to be looking into detail that. And they have expanded the electronic health information access to different individuals. Also, there is a policy about information blocking, and there are penalties up to $1 million per violation. And this violation that you are blocking the flow of data or information, you can be fined, and it's in place in September 1, 2023 for specific actors that they are obligated to disclose or move the data. Then this evolves annually. The draft version for 2026 just got out, and you can go and take a look in what are the standards, and we are going to review that in the session of standards. And they also enforce the admission, discharge, transfer, e-notification of the different actors since 2021. Then this CURES Act has been evolved into a new figure, and this Health Information Exchange that is now called TEFCA, or the Trust Exchange Framework and Common Agreement. It's live since December 2023, and this is a nationwide exchange governed by the Common Agreement. This is the first attempt to have a federal framework, because before we were in the state level. And they create multiple designated qualified health information networks that interconnect their networks. Then basically these are network of networks or a network of health information exchange, and there are some examples, some names there. And now you can see that RIOs are no longer the core federal approach, because even they didn't fund that. And this support treatment, payment operations, public health benefit determination, individual access services. It's a really big and robust framework for different transactions, and the standard that is facilitating this is FHIR. And they have different versions, and the one that is effective right now is the version number 2. Then at the end, the standards in practice is FHIR revision 4, and this allows for access and it exchanges information in the patient level or the system to system exchange. We have the USSDI is the baseline content standard. Then there is already published the new version, and TEFCA facilitates scale those APIs cross network queries. Okay, if we think about those population health enablers from the community model, then definitely the use of ADTs, the admission, discharge, transfer, and the e-notification, the conditions participations, they are going to help us to drive timely care transitions and to move that data from different actors and try to remove that barrier of the competing actors not sharing the data and repeating things that we didn't need to repeat and making the data to flow. We can leverage in TEFCA and the Queens to reduce those gaps when that problem, when patients go across networks, across providers. And maybe we can align models to the US CDI to be able to have consistent analytics and reporting, because the way that the data was extracting was not really standardized, and there is a plethora of different ways of exporting data. That has been a challenge, no? And they try to close that gap. Then we can think that there are different ways to structure this. Then you have party-to-party or two-point agreements. You have two-party health information participation agreements. You can have a multi-party agreement. Basically, these are the different ways, but now we are moving to that multi-party agreement, and TEFCA common agreement via Queens is perhaps that facilitator that is going to be opening that door to actually have access to a more robust population health information systems. Okay, now that we understand the evolution, the regulations, and the way that the system works, let's look into some methods and frameworks that we can apply to design, develop, or structure the architecture of these systems. Then the first approach that I want to bring is the Open Group Architecture Framework, or TOGA. Then it has requirements in different domains, and you gather that information and you integrate them, and basically a pool of discrete components, and every single of those circles is a project and is a manageable form. This is easy for stakeholders, donors, and system suppliers to understand, because you just decompose the whole architecture into these small pieces, and it helps to move from functional requirements towards developing technical specifications. That's design and develop the software or the hardware that we need. Then effective health information systems need to look at this whole system instead of looking at it from a disease or domain specific point of view. Okay, this is really important, because sometimes in healthcare we just go to disease. And the TOGAF business scenarios can be used to identify and understand requirements in architect system whole way. There is another framework that's called the Sagman Enterprise Architecture Framework that was established in 1987. Then this is a model that tells us how enterprise managers and their information technology can work together. It uses a two-dimensional structure to describe the information architecture of the enterprise. The first dimension is about the roles, and the second dimension is about the attributes of the system. And this is a graphical representation of those domains. And at the end, the Sagman framework for enterprise architecture is going to have an enterprise model that describes what the enterprise does or should be doing to meet the mission. It has an information model that identifies and defines the subject entities about which the enterprise keeps information. The application model identifies or defines the set of applications that support the enterprise and information model. It has a distribution model about the physical distribution of entities and applications of the model in different locations, how we move the data, how we exchange the data. And the technology model is the blueprint for the development of integration of that IT into the enterprise in the existing infrastructure in the future. There are other approaches as well that we have, for example, the business process management notation, the BPMN. Then this is another framework that is a graphical framework to represent that business processes. And you may be familiar with that, where you have the pool, you have the functional roles, then you have a notation with a process start, with a process end, the sequence flow, what is an activity, what is a sub-process, how a decision is represented, how you connect to other parts of the flow, and you can have annotations. Then in this domain, there are several tools that we can look and explore. One of those tools is called a Visagi Modeler. It's an interesting tool that I have used in the past that allows you to graphically describe the models. And Visagi Modeler is actually you can access for free. And this is a visual editor that it's really intuitive to understand processes, and then you can put there the different information flows, the different requirements. This is more in the operational way, but when you have this type of tools, you can actually automatize process, and that's where new information systems are moving towards. That once you have modeled your process, you can automatize that and deliver that. And the other way, the other tool that we can look at is called a Decision and Process Maker. Decisions and Process Maker is another tool that also optimize, and orchestrate processes. And you see now, AI is serving all these tools to facilitate actually the integration of a movement of data. Then those are interesting tools where you can use to model the business process, and actually that modeling is really important for any framework that you want to use. Also, when we talk about creating a solution, then another framework that we can use is the Information Resource Management Planning, or the IRM. Then this understands, simplifies, and integrates public health enterprise itself. And it has a metaphor for a systemic planning approach to building an enterprise-wide information system. Then the information system has to develop the business view and the information technology view, similar to the segment, now bringing those dimensions and representing the overall public health process and objectives in the business view, while the information technology specifies the technology and the implementation details. The business view represents what, while the information technology view represents how the process needs to be implemented or automatized. And in this regards, IRM is a set of principles and practices in which an organization can manage its information resources. Then basically how we manage data, how we manage applications, technology, and we need to understand that information is one of the public health organization's key strategic assets. Nowadays, people consider data as the new oil or the new gold. And when we think about information resource management planning, it's a process by which an information architecture is developed. Then specify how to achieve the agreed architecture and provides business guidance to those in the public health organization to develop those information systems. This is not just IT planning, no? This requires a high-level review of the business, its goals, procedures, customers, organization structure, and requires ongoing executive sponsorship. Yes, if you don't have the leadership sponsorship in this type of projects, generally you are going to fail. You need the buy-in of the decision makers in any of these type of transformations. You need to get stakeholders involved, and you need to think that stakeholders is anyone or any group that is affected by the actions of the organizations, or that they're going to be interacting with the health information that we are providing. Then, for example, if we have a state health department and we are doing an IRM for them, it should include the partners in the local health department, the community groups, the clinical care professionals, the allied state and federal agencies, the general public. A common problem is that we define those stakeholders too narrowly. We don't think big enough and we leave people out, and that's one of those common failures. Then some steps in resource management planning imply to simplify the business. You want to reorganize and use the information technology or both, and you want to arrange public health information systems in such a way that data, software, and technology that are shared across agency. You don't want to have duplication of facts, data, or things, because that creates confusion. Which is the real one, which is the updated one? Then that's part of the things that you need to be aware of that. How do you implement and migrate this? Then basically you need to define scope and sequences of a comprehensive set of projects, and you need to take into account the human challenges, the organizational challenges, and the technical challenges. As I mentioned, usually the technicals are not the most difficult ones. The more difficult ones are the organizational. That's why you need the leadership buy-in, and the humans, because we all want to be in the spotlight. That's something that we need to overcome. And change management is really important when we are doing any implementation projects. But at the end, We want to enhance interoperability, support efficiency, reduce the redundancy of data entry, guiding plan across projects. We want to have component orientation to develop process. We want to have easier upgrades, easier incorporation, security, and data backup. These are the things that we want to think when we are implementing this. And if we want to design a community-based health information model, then it has to be a strategic that is focused primarily in the local market or that community, and it has three foundational steps to look into the market and assess both opportunities, threats that the health system might be facing. Okay, you need to understand the payer dynamics. You need for the look at the community health needs, and you need to map those community assets. And once you understand really the dynamic, because yes, who pays for what is the money, then you can map those needs with that. And the assets, then this triangulation is the way to optimize things. We don't want to reinvent the wheel. We don't want to bring solutions that they are not needed. And we don't want to push technology that is not required to a problem that doesn't exist. And take into account that now we have this framework of FECTA and QUINS and how we can integrate with them and not be just isolated of that. Then in summary, we explore quickly the difference between health information system and the population health information systems, different factors that influence these different approaches, a little bit of the history, a little bit of frameworks, and then a reflection about how we can move this into a community base. Thank you very much. Looking for discussions, and I hope you find this information useful. Until next time, thank you.